So I want to say what a great pleasure it is to come to London and spend 2 days with your entire program, the residency program, the faculty. Everyone's been so nice and very welcoming, and I want to say thanks to all of you. Claudia's been such a great host and tour guide of London and the hospitals, and it's been a really fun day today. And you should be very proud of your residency program. The residents are nailing all the cases today, and we had a good, I think we had a good case review session and a couple of little didactic talks on various different things. So it's been, I think it's been a fun day. I hope, certainly for me, and hopefully for everybody else. So, and thank you, Allison, for spearheading this invitation and for your kind words. And it's really a great honor to be here. These are some relevant disclosures to the presentation tonight, including in-kind research agreements with Siemens, speaking fees from Bracco, and I'm going to talk a little bit about pancreatic cancer and MR tonight as well. And I should tell you I'm board chair for this organization, which is doing great things for pancreatic cancer awareness. A little bit about me, which you already heard, I think, from Allison, but this is kind of my background from engineering into medicine, and then very accidentally into radiology after I met somebody at my medical school library right before I was applying for CARMS, who a classmate who told me, why do you want to go into internal medicine and nephrology? You should go into radiology. I said, oh, that's a good idea. I'm going to change all my electives, and I changed all my fall electives to radiology, and that's it. That's how I ended up in radiology, so it's really good. Yeah, he reminds me very often about that decision, yeah. And I was a fellow in Chicago at Northwestern and got a chance to do a really fun body MR fellowship, and when I was there, I was very interested in cardiac MR and MR angio, and it was right before all this stuff with NSF took off. It was kind of the year before people learned what NSF even was, and it just turns out the cardiac MR fellows that year dropped out of the program, and so I got a chance to kind of do a lot of body and cardiac MR. So a lot of like random circumstance goes into leading people in a certain direction. And I spent a couple of years in private practice in the U.S., in Dallas, where I learned a lot about practice management and busy clinical services and private practice. And then I came back home to Toronto, and now I've been at St. Mike's for a really wonderful 9 years, over 9 years. And some of the things I've been involved in at St. Michael's Hospital and have had the privilege and great kind of experience building is really around building research and clinical MR programs. So we have 4 MR scanners, 1 dedicated research scanner and 3 clinical scanners, 2 3T, 2 1.5T, all real state-of-the-art stuff now. I'm proud to say we've built a really modern, diverse, busy clinical body MR program where we do in excess of 50, abdominal MR exams, well over 50 a week, in all kinds of different areas for our single site. We have a research center which we created in 2013 with CFI funding, which before we started that with CFI funding that came from some clinical research colleagues, which before that we had really no research MR infrastructure at all. And today we've created a profitable business unit for the hospital. It has revenues of close to $1 million a year. That's research revenues from agency and industry funded research studies, and it's generated a lot of research activity for our radiologists and for our colleagues outside of radiology as well. And I've had a chance to be involved in building that. We have some fantastic, every year we have great cross-sectional imaging and body MR fellows, including our current fellow Peter Yang, who's an alumnus of your program. I'm also proud to say I'm a colleague of Amy Lynn, who's on staff now at St. Michael's Hospital. She says hello to all of you. So we have a great clinical environment, and we've been able to create a new CME program that I think Alison was talking about previously as well, called the St. Michael's MRI Symposium. This year is the 5th anniversary of that program, and this is some shameless promotion of a CME program that we're doing. But this year it's in September, and we have a whole kind of theme on MR safety and a lot of some guest faculty, and talking about gadolinium, talking about MR safety issues, and then kind of some advances in abdominal MR. I think that'll be a great event in September. So please try to attend if you can.
Can I interrupt?
Sure.
You know, the best thing about that is there's no registration.
It's free. Yeah, it's free. I should tell you that too.
It's unbelievable. And they network it, so you don't need to drive in. You can stay in your basement and watch it on your big screen TV.
Yeah, we have people from coast to coast on webcast, and
awesome.
yeah, and if
Yeah,
that's right. We're raising the stakes this year to have some understanding from my colleague about MR defecography, which I think is a really important imaging service to offer, actually. So little.
send us the flyer?
Sure, I will do that. Yeah. So I thought tonight we'll get into some kind of philosophy about MRI. I thought we'll kind of talk a little about a few different topics and kind of bring them. And the unifying theme of the different things I'm going to talk about tonight are really the impact of MR, and trying to focus on impactful MRI studies and clinical indications for MR, and where MR is going, and how, you know, moving from kind of low impact to high impact applications and research and clinical aspects of MR, you know, how we're seeing that evolution go from low to high to kind of higher and focused impact studies. So I kind of divide it into 4 parts, this talk, and hopefully it makes sense by the end of those 4 parts. Hopefully they all fit together. The first is going to be, you know, some historical perspective of what the problem with MRI research has been, you know, in the past with regards to impact. And then I'll talk a little bit about, you know, some of the screening that we currently do or have talked about doing with MR that's kind of not that well steeped in evidence, or, you know, not kind of great applications of MR, but they're common parts of clinical practice, or they have been considered for clinical practice, and what some of the specific challenges with those are. And then I'm going to just review 4 what I think are impactful MR indications that have good evidence behind them. And those 4 indications are rectal cancer, prostate cancer, liver fibrosis, and in general diffuse liver disease, and Crohn's disease. And then we'll just look to, you know, the future of what, after learning all this, what, you know, the future of abdominal MR can look like in terms of value and impact, and what are some of the characteristics, I think, you know, that we might focus on in the future for abdominal MR applications, using some stuff that we're already doing today. So let's see how that goes. This is a little cartoon kind of showing what, you know, how MR has been really run in the, you know, in the past, which is we got this great machine, and now we got to do some investigations to justify it, which is you know, which is a lot of what's happened in the past. So I guess you could ask, if you're talking about MR research and you know, and looking at what's been lacking, you can ask 3 questions. Are we developing great technologies in radiology? Are we advancing scientific knowledge? Are we advancing human health? 3 important questions to ask in not just MR research, but research in general. And I think that there's no doubt that we've been making great technology. Look at our field. I mean, it's just ripe with amazing technology. Look where we've come in 40 years in terms of you know, where we were maybe in the 1970s in terms of imaging, which was really you know, M-mode ultrasound and X-ray and a bunch of angio studies, and look where we and look with the kind of things that are available to us today. And there's no doubt that we're advancing scientific knowledge. We've filled the literature with scientific knowledge and imaging technology. But the question is, are we really advancing human health with all this work that we've done in the past in MR? There was a plenary session, the Lauterbur lecture at the ISMRM, the big MRI Society meeting that's held annually across different cities. It was in Melbourne a number of years ago, and Vivian Lee, who's a luminary in abdominal MR research and kidney MR in particular, gave a nice talk and a nice introduction, and the point that she made was around the impact and the state of MR research. And she outlined the top 10 medical problems worldwide by the total healthcare expenditures that they have in the Western world, and ranked them from 1 to 10 by measure of that impact of those diseases and those entities. And then she looked at the year before's MR abstracts at ISMRM and counted how many of MR abstracts were in each of the, were advancing, our understanding and our knowledge of each of these fields. And she did a correlation, she showed a correlation graph and, came up with statistical measures of correlation. And as you can see, without even knowing what the statistical measures are, there's really no correlation. Like there was really, we weren't focusing our MR time and our energy and our research into maybe areas that made the greatest impact on human health. So her point was that maybe we should change our focus a little bit, and we'll talk a little bit maybe how we can do that. And other lectures in later years at ISMRM have talked about how MR has become the gold standard for many different disease entities. These are just some examples in the upper group. Stroke, quantitative and qualitative assessment of cartilage, cardiac iron overload in hemochromatosis and measurement of T2 star, relaxometry in the myocardium, rectal cancer. These are areas where MR is unquestionably has the greatest amount of high quality evidence that it's just it's essential to our understanding of these concepts. And these are some areas I think that are models for us to look at how we want MR research to move in the future. So the answers to these questions are as follows, and we're in the past have not done enough to focus on the last question in MR research, but I think we're making great strides, and I'll show you some examples of some of that tonight. So what do we need in MR research? We need to focus on clinically impactful problems where effective therapy exists, and if we intervene with imaging or image-guided therapy, would make a difference to the management in patients. And we need to try, it's very hard to do it, to validate MR as a biomarker of disease. We need to compare to gold standards. We need to show that it's a cost-effective technique. This is a very expensive, we are expensive. Radiology and imaging in general is very expensive. So we want to kind of do these big things, gold standards, show its cost effectiveness, and show its impact in populations. And I think we'll move that conversation forward in terms of MR research then. Two potential areas where we may be, these are two examples I have of where we may be moving MR into the mainstream for impact on clinical medicine and on human health. This is one example of a study that I've been happy to be involved with as a site PI at St. Mike's. It's called the Canadian Alliance for Healthy Hearts and Minds. It's a Canadian multi-center $16 million funded trial looking at risk factors and the root causes of cardiovascular disease and other chronic diseases, kind of like an imaging Framingham study, where one of the main components of assessment of root causes of chronic diseases like cardiovascular disease is use of MR, which is a pretty unusual thing that cardiologists and epidemiologists and internists are looking to MRI as a potential measure of, as a way of measuring risk and root causes of diseases as impactful as this. And over about a 5-year period, over 8,000 people completed this study. These are 8,000 people across Canada who had MRI scans of their brain, their carotid vessels, their heart, their abdomen. Imagine the kind of data that we can get from that, and correlating with their cardiovascular risk, with their histories, with blood work, with all kinds of things. Over 750 of these people were scanned at my hospital. The study used 7 different regional or provincial health cohorts across the country, 13 MRI centers, including here. There's a scientist named Grace Paraga who was an involved co-investigator in that study in London as well. And in over 4,800 patients, we had patients who had all of these 4 MRI studies done in the same, at the same sitting. So lots of data that's now kind of starting to trickle out. The PIs for this are Dr. Anand at McMaster at the Population Health Research Institute, Matthias Friedrich, who's a cardiologist in Montreal, and Jack Tu, who's at Sunnybrook. And just to show you, I'm not going to go through data, this is unpublished data, but just to give you an idea of the kind of impact or data that we can have that's coming out of the study, is just a graph that shows the heart risk the risk scores of patients, their cardiac risk scores that have come from history and vitals and physical exam findings and questionnaires, nothing to do with blood work, nothing to do with imaging on the horizontal axis, and the percent of patients on the y-axis who had the following MR findings. Cardiovascular abnormalities seen on MR, measured with a bunch of different metrics, excessive ectopic fat in different areas, abdominal fat, pericardial fat, and a mix of cardiovascular and ectopic fat findings. So they're looking at vascular phenotypes and fat phenotypes on MR and looking at correlating them with cardiovascular risk. And there's strong data coming out of this to show that there are clear connections with these kind of measurements. And so I think the kind of work that's going to come out of this is going to show the utility of MR, maybe in even predicting risk, or in at least risk predicting subclinical disease on MRI. And I think that'll be something that we're going to see more in the future of MR. Another example is something a bit more specific, which is an area that I'm working in, which is in the area of kidney transplantation and kind of kidney and kind of renal disease in general. People who get kidney transplants, who, as you can imagine, wait for years, sometimes a decade, to get a kidney transplant, often fail over a relatively short period of time after they get a transplant because of this entity called chronic allograft injury, which can have many different etiologies, but it all leads to fibrosis. All these different disease entities that cause transplants to fail lead to fibrosis. And fibrosis is a big part of progression of disease, both in kidney transplants and even in native kidneys and even in many other organs as well. And so, maybe there's a way. So this is an example of looking at an impactful disease, fibrosis in the kidney or in a kidney transplant, and seeing is there a way to use MR to benefit these patients. So this is just an example of one patient. We published this in a case report showing a fairly normal biopsy of a transplant kidney 2 years post-transplant. The patient running into clinical problems, and at about 3.2 years post-transplant, where there was clinical manifestations of kidney disease in this transplant, this patient had significant development of fibrosis on biopsy. And we were able to find in these same 2 patients a big difference in their MR elastograms, looking at MR elastography as a measure of stiffness. Hopefully, we may find a relationship between that stiffness and fibrosis, and showing that in this one single patient over a 1-year period of time, a significant change in their elastogram that correlated well with their biopsy findings in those same kidneys, where our stiffness measurements, does this mouse work? Yeah. Where the stiffness measurements are quantitative measures that can change over time and are shown visually in this color map as well of this MR elastogram of a kidney. We'll talk a little bit about MR elastography a little bit later. So, a lot of people, we talked a little bit about this today, accuse us of over-imaging people, but sometimes we're not really over-imaging. We may not just be imaging appropriately, and the same thing goes for MR research. We may be not doing MR research and focusing our MR research in the right areas, and we have to sometimes turn things on our head and say, what are the clinical applications, and then go and adapt and find the MR application that fits that, or that helps us answer that question. So I'll turn over to MR for screening, and just to give kind of two examples of areas that I think highlight some problems with the use of MRI currently, and can be useful to consider what problems we might have with MR in the future. So MR can potentially not be very impactful as a screening test if it's too costly, if it doesn't have proper cost effectiveness, or if it doesn't have a suitable population and maybe not a suitable disease for screening. It's a disease that's not suitable for the application. The cost problem is, the questions are, is this an appropriate cost? And you can measure, a lot of people are now looking at cost effectiveness in radiology. They're measuring cost effectiveness as dollars per quality adjusted life year, and looking at the cost of tests per this metric of quality adjusted life year, and making decisions on appropriateness of imaging, not just MR but other things, based on this kind of a metric. And then the other question, as we always ask ourselves, is there a cheaper available test that's going to answer the question better or as well? Hepatocellular carcinoma, I think, is a good example of this problem in using MR for screening. Why is it a good example? Well, it's a good subject for screening for sure, because it's a common disease. It has a survival benefit when you catch it early. Early stage disease has curative or at least very effective treatment. And we know that surveillance improves survival. And we know that non-imaging methods of surveillance, like alpha-fetoprotein and other blood tests, are kind of disappointing or not very useful as a screening test. So we know that there's a real rationale for doing surveillance on these patients with imaging. This is just a list of the kind of patient scenarios and the diseases that they may have that justify, according to guidelines, screening. And they're in general patients who have a greater than 1.5% per year risk of developing HCC over the course of their lifetime. And this is a group of patients who we would say we should screen these patients with imaging. Well, if we're going to screen them with imaging, what are our choices? We have kind of three choices: ultrasound, CT, MR. As you know, for sure, MR is a fantastic test to detect HCC. At a per patient level and at a per lesion level, it has superior statistics around the detection of this disease and the characterization of this disease. It also doesn't use radiation. The problem is it's very expensive. And for a screening test, it doesn't justify, despite its superiority over other techniques, it doesn't justify its use as a screening modality as much as we might want it to be, because we think it's such a much better test. And so even though ultrasound has this wide range it has operator variability, and it has wide range of accuracies and sensitivities depending on in whose hands it is, although I would argue that in the right hands and experienced sonographers, experienced radiologists who do liver, it can be a very strong and very accurate test. We know that for sure it's accessible, it's much cheaper, and as a result, all guidelines use ultrasound as the most rational choice for a screening test for HCC. And that's despite the fact that we know that these people may have fatty deposition of the liver, and MR is the best test to assess for fatty liver. We know, and MR, using plain old in and post-phase imaging compared to CT and ultrasound. It's also despite the fact that we know that MR is a better test for the detection of focal liver lesions. These are ACR appropriateness criteria tables that show us that MR is a superior test when it comes to characterizing liver lesions. Despite all of that, we still know that ultrasound is the best test for screening HCC because of this whole cost-effectiveness issue. So, MR by its very nature may not satisfy the criteria to be used in screening tests for many different diseases simply because of this problem. There is also another potential problem with using MR for screening, and that is we may not, though we may think it is, we may not have a suitable patient population. We may not have a disease that's suitable for screening, even though we want to use MR to screen to screen for certain things. And so you have to think about the impact and whether intervention makes a difference, and all the kind of epidemiology things that people talk about with screening tests. We have to think about those things when we choose MR to screen for certain diseases. And sometimes we don't even know we're screening for diseases and we're using MR to do it. I think a good example is pancreas cysts, and I'm just going to spend a couple of minutes on pancreas cysts, which, as everybody knows, is the bane of every abdominal imager's existence. It's a major part of our, unfortunately, major part of our practice. So how did this happen? It's very prevalent, as you know. The vast majority of these incidental pancreas cysts are small. And we do know that there's all kinds of studies, a lot of them in the radiology literature, that have associated pancreatic cysts with an increased risk of malignancy. But we know that that risk is very low. It's even lower in terms of its association with solid pancreatic ductal adenocarcinoma. But yet, because of this thought that it increases the risk or it has some association, we choose to do all these imaging tests, all justified because we have tons of radiology guidelines that tell us about the justification for doing these things. And the real bane of the real kind of crux of the problem is this particular diagnosis of IPMNs, which we all have heard about. They do have this low rate of malignant transformation. They are associated in many different types of designs of studies with a slightly higher risk of pancreatic carcinoma, and they do in fact behave or can behave differently in high-risk individuals, individuals who have a higher risk for pancreatic carcinoma because of familial or hereditary reasons. They can behave more differently and more aggressively in those people than in a normal population. And there's a wide differential for these pancreatic cysts, but this is probably one of the most important differential for those pancreatic cysts. But if you really think about what we're doing when we're doing all these next time you do a follow-up IPMN MR and you look at the cyst that's been followed for 5 years and it grew a few millimeters and there's no solid nodule, and all this, you think about what we're actually doing. Because of this supposed association and this connection with pancreatic cancer, what you're really doing is you're taking it upon yourself to screen for pancreatic cancer with MRI. That's what I think we're doing when we do IPMN follow-up MRs. So if we're going to do that, we should ask ourselves a question: is this justified? Is this really is this an appropriate thing to do? There's a couple of papers that I would just kind of highlight in this regard. There's a nice radiology paper from a few years ago where a group from the Bronx in New York looked at 8,000 patients. They took like government databases of patients, and all patients who came in who had a CT or MR findings of pancreatic cysts, and looked at all these people and found, in fact, that there was some relationship between the presence of IPMNs or the presence of pancreatic cysts in general and the development of pancreatic cancer. But importantly, in patients over the age, they looked at a measure that we don't look for very often in radiology because we're looking at growth of cysts or nodule development. They said, forget all that. We're going to look at mortality, all-cause mortality. Did the patient survive? Did the patient die or live because they had this pancreatic cyst develop? And they saw that in patients over the age of 65, there was no change in all-cause mortality when a patient had a pancreatic cyst versus they didn't have a pancreatic cyst. Hazard ratio was the data that you see here, and they clearly showed that this didn't seem to have any relationship with their all-cause mortality. So that's something to think about. And the other thing we should think about is if we're going to adhere to some of these guidelines around pancreas cyst MR, we should probably go look at what the pancreatic cancer literature and what pancreatic cancer experts are saying about screening for pancreatic cancer and whether we should be doing it or not. So what does it say? Well, if you look at this paper from this International Pancreatic Cancer Consortium on Screening, it's a specific screening consortium for pancreatic cancer. published in Gut, very high impact journal, a number of years ago, looked at a list of all of the screening trials that have been done. This screening trial here from 2011 was done at UHN in Toronto, and these are all the trials from around the world over the years that have looked at pancreatic cancer. All of them have been done in, the only groups that they have felt justified to do these screening trials are those with familial pancreatic cancer, Peutz-Jeghers syndrome, BRCA gene abnormalities. These are all people at significant hereditary or familial risk because their baseline risk for pancreatic cancer is so much higher than the baseline normal population that they hoped that at least some positive result from the screening would result. And basically, all of these trials, in terms of their detection and change in outcomes for pancreatic cancer, have been a failure. We haven't found in even these people who are at significantly high risk, in some trials 13, 15 times the risk that a normal population has for pancreatic cancer. In these people who were at a much higher risk than somebody with an ipMN, screening didn't work. As one example of that, and this is another table from the same paper showing the recommendations that came out of this consortium and this working group, and all of these statements about who should be screened, you can see here who should be screened, all describe groups of patients who are at high risk. I mean, there's 9 statements here around them. None of them are around ipMNs or pancreatic cysts or anything like that. In fact, they can't even agree on what modality or what test we should do to screen. How should high-risk individuals be screened? Nobody can even kind of agree on that. They're still debating between endoscopic ultrasound and MR. So, and this was one paper from Steve Gallinger at UHN and Mount Sinai Hospital that looked at, that created a screening trial for 262 patients screened with MRI every year. These were people who were at extraordinarily high risk, 13 times the risk of pancreatic cancer than baseline population. They found 3 pancreatic cancers. They couldn't intervene. All 3 patients died. They couldn't intervene and change outcomes in any of them. And they found, in fact, that in many of those cases, when they were screening every 1 year, 1 year is not frequent enough. You're gonna lose your effectiveness as a screening study if you're going to follow these things every year. And they found many ipMNs and other cystic lesions, none of which progressed at all in that trial. So I don't know, it's just a thought to you that it's not really been established in the pancreatic cancer world who should be screened. Nobody has ever suggested this group of patients with pancreatic cysts to be a screening population. There is some, although I will say there is some justification to maybe look at people who have ipMNs who are themselves high-risk individuals and potentially screen them, but that trial has not really been done. It's not even established how we should screen patients who are at risk for pancreatic cancer. And we don't even know what frequency we should be using because 1 year, if you really think about it, doesn't make a lot of sense in this disease. So despite all of this, we've taken it upon ourselves to screen all kinds of people with MR for essentially for ductal adenocarcinoma of the pancreas because of a risk factor that we think is important, but I don't think is really well established. So I think this is kind of a little bit of a controversial thing, but I would say we should really think about whether that's the right thing to do, despite a lot of guidelines that would tell us that we should screen for ipMN at below X number of millimeters or X number of centimeters at this frequency in this age group at that, I don't think we really know. And yet we do a lot of this every day. And so I think it's an example of, do we really have the right disease? Do we really have an appropriate target for screening an MR before we jump into using MR every day for such an indication? So I thought we'll focus the rest of the majority of the talk on body MR applications that actually do have a good indication and do have strong evidence for what we do. And luckily we all do a lot of these kind of tests. The first one, and I think one of the prototypes and models for MR and strong evidence and well-designed trials, is rectal cancer. Really an amazing advancement, I think, in a disease entity where MRI has just made a huge impact and a real impact. And the issue, as you know, with rectal cancer is the rate of local recurrence. It's much higher than in colon cancer, in non-rectal colon cancer. And there's a standard surgical therapy, this total mesorectal excision for T2 or higher lesions. And we know that advanced stage tumors really do benefit from a treatment regimen and neoadjuvant chemoradiation therapy that really does make a difference. So in the old days, you used to have recurrence rates that were higher than 30% in rectal cancer. They devised this new surgical technique called total mesorectal excision a long time ago, and that recurrence rate came way down. And then there was this advent of neoadjuvant chemoradiation, which the recurrence rate came even further down. And MR, had the benefit of coming into this, to this kind of algorithm and really allowing us to triage patients to get, neoadjuvant chemoradiation or go straight to surgery and really make a difference in those people and be able to use our resources properly based on good evidence. So, we know that tumor involvement of the resection margin predicts a high rate of recurrence. We know that proximity of the tumor to the resection margin and the depth of invasion of that tumor are more important than the simple TNM stage or the simple T stage in these tumors. And we know that predicting a free resection margin has a high clinical impact. All three areas are areas where MR has ended up showing a great potential role and can impact, our accuracy and our ability to say all these things with a great level of accuracy. So the key with rectal cancer MR, as you know, is that we don't, spend a lot of time on T-staging. MR is not that great at T-staging. As you know, if you really want to T-stage appropriately a rectal cancer, you should do an endorectal ultrasound. MR is not that great at it, but it's a fairly low clinical impact metric, so we don't really care that much. But what we do know, and which is very high clinical impact, is that MR can predict a free resection margin very well, and it can predict clinical outcomes based on several metrics, two of which are the extramural depth of invasion, which we saw a little bit today in our case review, and extramural venous invasion, both of which you can tell with a high level of accuracy on MR, and which really do predict outcomes. This is just a schematic showing how they do total mesorectal excisions, taking them out, resecting along the mesorectal fascia in the at least in the non-peritonealized portions of the rectum, we know that MR is more accurate in predicting the free resection margin than T-stage. So if we can really assess that resection margin well with MR, we're going to make a huge difference. And we have done this, and this is old news, but MR has really shown itself through really good literature to be excellent at this. I'm going to skip that. And we know that there's a strong correlation between the pathology, the CRM assessment at pathology, and the CRM assessment at MR. So I'll skip some of this because I think we all kind of know this stuff. The Mercury trial was really the trial that showed this very well. And some of the numbers around this for some of those metrics that I talked about are, extramural depth of invasion below 5 millimeters. You have this high 5-year survival rate. Suddenly you go above 5 millimeters and it really drops. So if we can tell that on MR, we're going to make a huge, this is called high impact, right? You can really differentiate people based on this parameter, and if we can predict it with MR, we're going to do very well. Whereas we also adjusted T-stage to reflect some of these things. In fact, T-staging changed as well as we learned more about depth of invasion through pathology and through MR. It made an impact to how these tumors were assessed with T-staging, which really, kind of came from MR as well. And you can see here a nice example of a tumor that is extending beyond the rectal wall, beyond this thin muscular layer, with depth of invasion that is significant and will predict a poor outcome in this patient unless they went on to neoadjuvant chemoradiation. So, survival curves like this are important to see. This is a curve just showing relapse-free survival versus time just based on extramural venous invasion, in the black with an EMVI negative patient versus if EMVI is positive, it makes a huge relapse-free survival difference. And this is something that we can tell very well with MR, where we want to look for lobulated or convex tumor margins around veins around the rectum and not mistake those for areas of spiculation or fibrosis. But if we can see this on MR and we can call it, we're really going to make a difference in changing management in these patients and give them the right therapy that they need. So we talked about the extramural depth of invasion and its impact, the involvement of the circumferential resection margin, its impact, and then extramural venous invasion. The other area that is important now is the issue of post-neoadjuvant therapy. Does this patient even need to go to surgery anymore? And the response of the tumor to the neoadjuvant chemoradiation therapy with MR. And now we're using this tumor regression grade. I'm not sure if people are using that routinely here, but I would encourage you to grade all of your post-neoadjuvant chemoradiation MRs with this mpMRI tumor regression grade. And even that assessment of a 1 to 5 tumor regression grade has been shown to be an independent prognostic indicator for patients. Nice paper from Gina Brown in 2012 just showing the difference between people who have a tumor regression grade of 1 to 3, which is considered a good response, and their overall survival. You can see it in the data in the red circle, versus those who had a poor response and their 5-year survival. Huge difference. MR is very useful at telling this stuff is really impactful. This changes, patients' treatment courses. Just some examples of tumor regression post-neoadjuvant chemoradiation therapy. Tumor regression grade of 3, which is a good response. Marked shrinkage of the gray signal tumor with development of dark signal fibrosis on high-resolution T2 weighted imaging, but still some residual tumor signal and some significant and some residual extramural tumor as well. Here's an example of a tumor regression grade 1 tumor, where you see with the arrow this intermediate signal tumor along the right wall of the rectum, and complete disappearance with replacement of a fibrotic band, showing just an excellent response to chemoradiation therapy. So that's, I think, a good example of MR being used to really with a really high impact. What about prostate cancer? Another great example of where MR has made a big difference. And the whole issue with prostate cancer is clinically significant versus clinically insignificant cancers. There's many clinically insignificant cancers that don't need to go to therapy. There's a big treatment difference. And as we've found out, clinically significant cancers versus clinically insignificant cancers correlates very well with histologic grade of tumor and Gleason score at pathology. It's a very common tumor, and it's often not seen well on any other imaging modality, including ultrasound and sometimes CT as well. And we have a relatively poor standard of care. Our standard of care today to find prostate cancer is a random systematic biopsy of the entire gland. One of the rare examples where, if we are suspecting a tumor in a gland, we just biopsy the whole organ or the whole gland rather than kind of focusing in on one area. We all know about PSA and its flaws, and so there's a real, unmet need for something to step up and do a better job than what we currently have, and that, I think, is where MR has really done a great job. Prostate cancer is a great example of how MR, and specifically diffusion-weighted imaging and ADC on diffusion-weighted imaging, correlates so well with pathology, it's like a virtual biopsy. Here's a nice example from radiology paper in 2011 showing how the ADC map in the 3 different examples, 3 different patients, 3 different slices through the prostate have different ADCs with corresponding different histologic grades and different Gleason scores of prostate cancer mapped out in the same axis between MR and pathology. This is rare to see this in imaging where we have such perfect radiology pathologic correlation. It's really exciting when you see that. Same paper showing how ADC changes very reliably and very predictably as you increase the grade and the clinical significance of a tumor. ADC goes down as the tumor gets worse. It's been shown over and over again in MR, correlating MR with pathology. This predicts outcomes. It's exciting when we have imaging tests like MRI that can predict outcomes based on just diffusion-weighted imaging here, ADC map. This is one tool only in the whole MRI and whole imaging toolbox that's doing so well. With ROC curves that look like that. When do you get ROC curves that look like this in radiology? Like, it's really not very common. ADC, the performance of ADC to distinguish just low versus intermediate or high-grade tumors is so good that this is why I think everybody's gotten really excited about multiparametric MR for prostate imaging. And we've come up with reporting systems, PIRADS, I'm sure everybody has heard of, and strong emphasis on T2 weighted imaging, high resolution T2 weighted imaging and diffusion weighted imaging. PIRADS 4 and 5 correlating very well with clinical significance with clinically significant cancers. The CCO has come up with accepted indications for multiparametric prostate MR, including these ones. May be an incomplete list and may change over time, but it's certainly gained acceptance in the urology world and in the radiology world to look for prostate cancer. So, new study that's come out is this precision trial, and this is a graph from that study that just shows how well our reporting system, PIRADS version 2, which I think a lot of people are using now, including at our institution, how well it correlates with clinically significant versus clinically insignificant cancers. Higher PIRADS 2 scores just have a greater percentage of patients who have clinically significant cancers. We're getting very accurate at telling whether a tumor and reporting on whether a tumor is going to end up being a clinically significant versus a clinically insignificant cancer. But we've been so successful with prostate MR that these difficult questions have emerged. One of the questions is, should we just completely change our practice and get rid of these random systematic biopsies through the prostate and just do targeted biopsies post-MR? And then the question that comes from that is that if we're going to do that, what if somebody has a negative MR? Can we just substitute MR in biopsy-naive patients or patients who haven't had a biopsy? Can we just substitute MR for biopsy and substitute MR for random instead of doing random trust-guided biopsies? And I think there's some answers emerging to these questions, but they're difficult questions. The first question I think is being answered, and I think is very close to being answered now. And the answer seems to be we should do targeted biopsies. And new data from a 2018 study in New England Journal Medicine, exciting when MRI comes into the New England Journal of Medicine, a precision trial, predominantly urology driven, looked at randomizing patients who had prostate cancer to getting an MR plus or minus a targeted biopsy, or just standard trust-guided biopsy diagnostic workup. Long story short, after looking at all these different parameters, they found that the detection of clinically significant cancers, which is what they care about in the urology world, is much higher in the group that was randomized to the MRI with the targeted biopsy, even if they didn't get a biopsy. Detection of clinically significant cancers was much higher in that group compared to standard biopsy group. And so there's evidence coming out predominantly through this trial that the detection of clinically significant prostate cancer is better achieved with the clinical pathway of doing an MRI with or without a targeted biopsy, rather than just in a standard biopsy alone. And these error bars and difference in rates of primary outcome of detection of significant cancer, you can see leans and favors heavily toward the newer pathway of MR and targeted biopsy rather than the old pathway. This is somewhere, this is an example of MR making a potentially huge difference, completely changing, a standard practice that was in place for decades. We'll talk about the second question to that later in the kind of future section of this talk, which is coming up soon. Liver fibrosis is a third area that I'll touch on where, we've made a huge difference in MR, a huge difference with MR. Chronic liver disease, as you know, is a very common disease, impactful disease. There's multiple ways to get chronic liver disease, as we know, infectious hepatitis, non-alcoholic fatty liver disease, many other conditions that can lead us to that path. And there's really an unmet imaging need. Again, biopsy is a flawed test. And nobody wants to have a liver biopsy. The ultrasound has problems as an imaging modality to assess the liver when there's chronic liver disease. So there's a real unmet imaging need there. And that imaging need has largely been filled by MR elastography, largely based on the work of Dr. Eamon at the Mayo Clinic. Where MRE has now emerged as an accurate, non-invasive method of staging hepatic fibrosis and really can replace now and has been shown to be a useful replacement of liver biopsy in monitoring patients. And there has been all kinds of literature, and I know in doing a little bit of research before I came here that you had a speaker, I think Dr. Tang, who spoke to you a lot a couple of years ago or within the last few years on MR elastography of the liver, so I'm not going to talk too much about it. He's far more of an expert in liver elastography than me. But I will say that this is in correlating MR findings with a quantitative metric like stiffness taken from MR elastography. It correlates so well with pathology and with histologic stages of fibrosis that you're seeing on the horizontal axis there, that this has really been kind of shown beyond the shadow of a doubt. You've got stiffness correlating very clearly with stages of liver fibrosis taken from a wave map and mapping that into stiffness maps of the liver. It's also a quantitative tool, which I think is another trend that we're seeing in radiology, in kind of impactfulness of radiology studies and MR studies. And that was just in the example of non-alcoholic steatohepatitis, but this has been shown in many different causes of chronic liver disease. And the idea is that stiffness, at least in the liver, is a very good indicator of fibrosis, right? And that can be, not necessarily true in other organs, but for sure it's been shown in the liver. Again, ROC curves showing phenomenal performance of MR elastography as a tool to detect fibrosis in multiple different scenarios, multiple different studies, multiple different cutoffs of fibrosis or no fibrosis. And so I think that this has really been shown very clearly now to have become a virtual biopsy test and a good example of a potentially focused liver MRI protocol that you can do without spending 45 minutes on a liver MR. You could in fact combine it with other techniques to do a very quick diffuse liver disease assessment. MR elastography for fibrosis, T2 star relaxometry with the multi-echo gradient echo imaging that I was showing in the case review earlier today, for iron deposition, for quantitative assessment of liver iron concentration and T2 star, and using Dixon techniques for accurate assessment of fat fraction to assess for steatosis. This can be done in 10 minutes. Quick liver protocol, focused. Maybe we're seeing kind of some of the future of abdominal MR moving into direction like that. And it's thanks to tests and development of tests like MR elastography for the liver, which is really allowing this to happen. And we're now starting to work in areas extending MR elastography to other organs, in the kidney, as I showed you earlier, and I will show you a little bit more in a few minutes. The last one, which I'm going to go through a little bit quickly, is Crohn's disease. We know now MR enterography is a very well-established technique for Crohn's disease. We do hundreds of these cases. Gastroenterologists and surgeons have all bought in to Crohn's disease assessment with MR enterography. There's too many MREs, elastography and enterography, I get confused. It's fit in very nicely into the armamentarium of imaging tests. The justification for MR enterography always was, and still is in many other MR tests, radiation dose. You know, as long as MR enterography can be shown, and it has been shown very clearly to be equivalent to CT enterography for assessment of Crohn's disease, for distinguishing acute from chronic disease, it wins because there's no ionizing radiation. And these patients, in particular, Crohn's patients, get tons of ionizing radiation over the course of their lifetime because they've had so many radiology bowel studies. This is the issue of radiation that I talked about. In addition to the lack of ionizing radiation, it also allows a few other advantages over CT, which are some superior areas of superior soft tissue contrast, and a very useful technique with coronal cine imaging that we do is dynamic assessment of the small bowel, which I think if you're doing an MR enterography, you should add this to your protocol if it's not already there, because I think it's very useful. And the data has been fairly consistent. Pooled sensitivities for the diagnosis of Crohn's disease, sensitivities and specificities very high for the diagnosis of Crohn's disease and MR enterography. Indices based on MR findings that correlate with disease activity, clinical MR correlating with clinical data on disease severity, on activity index in Crohn's disease. It correlates with surgical findings of strictures, abscess, fistula, all seen in the literature very clearly. It also makes an impact in changing management. We've had literature that has shown that compared to not having done it, it changes management and escalating either medical or surgical therapy in large percentages of patients, and influencing therapeutic strategy of clinicians. So this has been shown over and over again. This is the kind of thing, again, that we want to see in the MR world, where we want to see real impact in changing clinical management. It makes us feel good to do exams that change management and change what people do in medicine. It's gained acceptance from many different worldwide organizations for being a comprehensive assessment of Crohn's disease. It's found its way into the ACR appropriateness criteria as a very appropriate test to do in many different scenarios in Crohn's disease, both in children, in adults, in assessing for surveillance, for mild symptoms, de novo, in many different scenarios. It's consistently being shown to be an appropriate and useful test. And it also allows us to use accepted radiology and gastroenterology terminology and lexicon in our MR reports. Lends itself very well to distinguishing between active inflammatory disease, chronic fibrostenotic disease, perforating fistulizing disease, reparative regenerative disease. These are all terms that we can use in our reports, and they fit in very well with doing MR. This is a paper that showed the Maria index of activity and its correlation and other clinical disease activity indices and its correlation with MR findings. Very strong correlation between what we see on MR and CT for that matter with clinical disease activity. I'm going to skip the show and tell of MR enterography because I think a lot of you know what Crohn's disease looks like on MR enterography. This is a normal case, but you can see how well we can see active inflammatory disease in Crohn's. You can see this mural stratification, intramural edema, mucosal and serosal enhancement with submucosal edema showing up as this train track sign on MR enterography. Mural hyperenhancement and thickening. Diffusion weighted imaging can be used to look for active inflammatory disease. Ulcerations can be seen very nicely to show active inflammatory disease on MR enterography. Mesenteric abnormalities related to acute disease can be shown very nicely on this technique. These are all cases from our hospital. Fistulizing disease really nicely seen on MR enterography as well. Abscess formation. So this is really a useful disease. You can look for strictures very nicely on coronal cine imaging, looking for strictures and obstructions obstructions. These all make big differences in clinical impact, pseudosaculations related to chronic disease as well. So what about the future? I'm just going to spend a couple of minutes finishing up here. A little cartoon to show you about functional MR and MR maybe in the future of how it might be used. I think the future use of MR in terms of what we've already talked about and what we'll talk about in the next couple of minutes can really be kind of picked three main take-home messages. One is this shift of the use of MRI being known as the last stop, right? After you work everything up, work up a liver lesion, the final answer is MR. And maybe in the future, what we're starting to see is the movement of MR in that spectrum of diagnostic pathways up the ladder to really using our heavy tools definitively at the beginning of a workup rather than at the very end. And there's lots of examples of that I think in radiology. And the second is going back to the first thing I talked about in terms of what was wrong, in the past in MR research. Get the right order of things. Find important applications first, and then develop MR techniques around those applications, or tweak MR techniques, or focus MR research studies around. Find the clinical applications that are impactful first, rather than finding the MR technique first and then trying to fit clinical applications into it. That's the second point. And the third point in terms of future use of MR is this whole area of high-value MRI, which I'll just touch on briefly at the very end, which may include trying to make exams shorter. Who wants to do a 45-minute, 60-minute cardiac MR? Why can't we make those 10 minutes? If we really want to have useful and inexpensive and accessible MR tests, they need to be shorter. And the only way they're going to get shorter is through technology development and making them more focused. And maybe the time is coming to have very definitive focused MR exams. So a good example, I think a great example of this MRI shift concept. I just made up the term MRI shift, but it's moving the kind of the use of MR up the ladder in our diagnostic workup. Is that second question I asked about prostate cancer, which is, can we start doing multiparametric prostate MR in biopsy-naive patients as a substitute for the standard way we do biopsy now? And this would be a complete paradigm shift if we can do this. We have this, right now what do? We do this flawed biopsy, which we may or may not find a tumor. For sure, if it's anterior, we're not going to find it on transrectal biopsy. If it's in the transitional zone, good luck. So we do this flawed biopsy, and then since they've had a biopsy and the PSA is continuing to rise, and they had another biopsy, and they had another biopsy, okay, we're doing MR now. So maybe we should be doing that MR right at the very beginning. And I think there's some literature that's coming out that's showing that this is not a crazy idea. This is really a useful idea. Precision Trial is one of them. This is another paper that came out very recently, 2017 paper in the urology literature, in European Urology, looking at the negative predictive value of multiparametric MR, a meta-analysis of all the trials that have been done in this area. What is the NPV of MR in excluding prostate cancer at biopsy? And what they showed basically is it depends. And what it depends on largely is how you select the patients for biopsy and how you select patients for MR. The patient selection is a big issue. But basically, the lower the pretest probability of prostate cancer before you do that biopsy, the more useful MR is. Okay, so the higher, so in men who may need to get screened for prostate cancer, but may have a relatively low risk for it, but still justify some investigation or some kind of a screening test, MR can potentially, according to this data, be very useful, because in those low risk patients, if I do an MRI and it's negative, I really should feel reassured and potentially stop and not need to do much further follow-up. And what this showed is as the biopsy positivity rate goes up, the negative predictive value of MR gets worse. And so that just shows you that if you really suspected prostate cancer so highly in a patient before you did the MR or biopsy and you got a negative MR, you're not going to believe it because you think they have prostate cancer. So, the potential value of MR is decreased in that. But in one of the studies that they did this meta-analysis on, which I think is a useful measure if you want a number in your head, in a population of high-risk cancers, Gleason 7 or higher, prostate cancers, who had a biopsy positivity rate of about 30%. So that's a fairly low biopsy positivity rate, meaning they selected a bunch of patients who would end up having a positive biopsy 30% of the time. They found that the negative predictive value for using MR for detecting PIRADS 3+ lesions, which are those that you're going to act on and you're going to not certainly leave them alone, was 88%. So 88, let's say 90% negative predictive value potentially in studies that have already been done where you have a general population of people, they get a negative MR, and you can be 90% sure that you don't have to do anything further. The Precision trial showed an interesting little side comment, which was that they looked, because they had two randomized groups, those that got an MR and those that got a standard ultrasound-guided biopsy. They looked at those who had those who got an MR and it was negative, and they looked at those who got a biopsy and it was negative. And then they followed those patients. And they found, in fact, that the people who had a negative MR, and then they didn't get a biopsy because they got a negative MR, the people who had a negative MR had less further follow-up diagnostic testing, PSA, biopsy, PSA velocity, follow-ups with urology, et cetera, than the people who got a negative biopsy, which kind of says that maybe patients and doctors actually feel more reassured with a negative MRI than they do with a negative biopsy. That's certainly how it was borne out here. None of these people progressed. None of these people got prostate cancer in the follow-up period of the study. This was published in the New England Journal, this goes to tell us that MR might have a real role here in moving up that chain, moving up that ladder to maybe start with a heavy-duty MRI test, but save people and save healthcare systems dollars down the road with regards to follow-up testing and follow-up biopsies and the risks associated with some of those tests as well. So the second thing is finding important applications. In the future for MR, we want to find impactful clinical applications first and fit the MR technology to them and not the other way around, which has been done a lot in the past. And there's many examples of this outside of abdominal MR. And in MSK, why are we not using MR routinely as a first-line test for avascular necrosis? How many of us do plain films for avascular necrosis here? We do it all the time. I mean, I'm sure it's done all the time. And maybe we should be doing MR only for these patients. Maybe, breast cancer, and breast cancer certainly does have a role for MR in screening. And there's many other applications where, we want to find important applications and focus our MR studies on those. This is another example that I happen to be working on, and since I'm here, I thought I'll tell you a little bit about what I'm doing, where we may be looking at an important clinical application where MR might help us, and that is the issue of kidney fibrosis that I showed you a little bit about earlier, and measuring organ stiffness with MR elastography as a measure of stiffness and maybe even inflammation and maybe even perfusion. And there's different ways that might be done. This is a schematic drawing showing the technique of MR elastography. I'm not going to go through it. This is some literature that we published last year showing in a very small number of patients, preliminary study, but first study to look at the stiffness measured with MR elastography in kidney transplants compared to their standardized pathologist, renal pathologist standardized score on biopsy for fibrosis called the Banff score, named after where they had the meeting where they decided on this scoring system, and showing that we are really seeing a relationship between stiffness measured on MR elastography and pathology. On top of that, we looked at outcome. We looked at how patients did in terms of their renal function over time after they had an MR. This is kind of a busy slide, but I'll turn your attention to this third graph over here. And basically, each of these lines is a patient. And the colors show the stiffness of their kidney measured in kilopascals from an MR elastogram done on that patient. And the red is worse. The red is kind of a higher, more stiff organ, suggesting more disease. The green, more green it is, the better, the softer the organ, less stiffness. And the measurement on the y-axis is basically GFR, basically renal function over time. Higher is better, lower is worse. And over time, what we were starting to find, and we're trying to study this in more patients, is that in patients who were already not doing great, which means they had a baseline eGFR kind of borderline or low, those people who had stiff organs tended to drop off much quicker. They tended to perform worse over time, and at least in early data, patients who, even despite the fact that they had borderline renal function, but they didn't have stiff organs, they didn't have potentially fibrosis or other things that would cause stiffness in their kidney transplants, tended to at least preserve their renal function and do better over a period of time of 1 to 2 years. And so this is kind of an early signal maybe that MR maybe can be used to predict. It's a predictive maybe tool for outcomes, renal function, and even maybe significant renal events like transplant failure or death related to transplant or other causes. And maybe MR could play a role in predicting that. And I think that's another potentially impactful thing that MR could do. And so we're working on now taking this clinical problem that we think is impactful and adapting the MR technology and adapting the MR technique to that problem. We're taking what we know about liver MR elastography and adapting it to, because a liver is very different from a kidney. It has many differences. The shear waves that are running through the kidney have to be, kind of captured and measured in 3 dimensions instead of 2 dimensions. We have to change driver frequency. We have to change our algorithm and have, try to come up with a complex inversion algorithm for post-processing. And we have to collaborate with people who are working, on this in other centers. And after doing this, we're finding some success in looking. This is an example of native kidneys, but we're doing this in transplants of native kidneys. It's harder in native kidneys because they sit deeper in the body. But we're finding that we're getting what looks like more accurate wave maps on MR elastography and being able to generate stiffness measurements in these kidneys and starting to look at this in patients who have disease and even those who don't have disease to try to see if there's any kind of signal here that this might be a predictive tool for renal function and for the development of renal fibrosis. And this might change what nephrologists do, because if they know that there's more fibrosis and less inflammation in an organ, they may be less inclined to give powerful, heavy-duty anti-inflammatory drugs that are going to have all kinds of other side effects in those patients. And it also might help in the development of antifibrotic drug agents, which currently don't have a good gold standard because nobody wants to have a kidney biopsy, especially they don't want to have a kidney biopsy of their kidney transplant that they waited 10 years for, and they're not going to let somebody put a needle into it for some research study. So I think this is kind of an area of potential advancement. The final area is high value, this whole concept of high value MRI. I think you're going to be hearing more about this in the future. There was very recently, a couple of months ago, a co-sponsored RSNA and ISMRM workshop on this concept of high value MRI in radiology, talking about the development of protocols of focused exams. I gave you one example, diffuse liver disease. Maybe instead of, we have a habit in radiology of wanting to get the best images and the most comprehensive images in every possible sequence in our protocols, and that's why they sometimes take 30, 40, 45 minutes. Maybe we should focus that down and look at a 10-minute protocol and get specific questions answered around diffuse liver disease, get a specific question answered for prostate cancer, maybe not even needing gadolinium. As we move to different newer reporting systems, it's looking like the importance of dynamic contrast enhanced imaging in prostate cancer is not as important as T2 weighted imaging and DWI. Maybe we can find a quick 10, 15-minute protocol for prostate MR to say yes or no, is there clinically significant cancer here or not. HCC screening protocols for liver MR rather than doing a comprehensive 30, 40-minute exam. And maybe MR protocols that are focused on pathophysiologies rather than just organ systems or anatomical regions, like doing a fibrosis-focused MR exam or an inflammation-focused MR exam. That might be something that we're seeing as a high-value technique. As I said before, using our most powerful imaging tools more proactively when they're appropriate, and innovating around value, value defined as a diagnostic benefit divided by cost, right? It's a benefit it's a cost-benefit analysis, essentially. And some of the issues around innovating around value that have been advocated by Richard Eman, who is the inventor of MR elastography and former chair of the RSNA, talks a lot about innovating around value and some of the issues around it being medical economics, technology availability, and really finding measurement techniques for value in MRI. And another part of the whole high-value MRI equation is just finding shorter MRI protocols, not just as a more focused exam, but to save cost, and using technology innovation in MRI to really to save cost. So that's it. I hope that all made sense. And maybe is coming together for everybody, and hopefully everybody got some take-home points. I'll just summarize some of the take-home points. More MR research is needed in high clinical impact areas. We may be actually under-imaging and not imaging enough in certain areas that are where the applications would justify it. Often, as is the example in my opinion about pancreatic cysts, we're not using MRI properly or well as a screening test. And there are many issues about using MR as a screening test that we have to be cognizant of, as we've heard of today. Focus on applications where MR has been shown to make big clinical impact, and participate. I think we should participate in showing areas where MR can have a big clinical impact. And some of those examples I went through, it can predict outcomes in rectal and prostate cancer. It correlates with pathology very strongly in prostate cancer, liver fibrosis, rectal cancer. And in Crohn's disease, it predicts disease activity, correlates well with clinical activity, and allows people to choose treatment pathways and treatment strategies in things like Crohn's disease, rectal cancer, and in other conditions as well. And finally, on the topic of high-value MR, maybe having this MRI shift of moving MR up the chain or up the ladder of the diagnostic workup, finding important applications first and then developing MR technique, and focusing on high-value MRI as we move into the unknown future of imaging. I want to acknowledge some of my colleagues, my three other abdominal imaging colleagues at St. Mike's, Dr. Kolak, Dr. Vlaku, and Dr. Manatsakanian, abdominal imaging colleague at UHN, Dr. Javeri, who all of whom have contributed some of the material and slides to this presentation, and some research collaborators at the Mayo Clinic, Dr. Eman and Dr. Arun Kolipaka at Ohio State University for some of the work in elastography. And with that, I'll apologize for going a little bit over, and thank you for your time.